Good morning. My name is Joy Hoskins. I'm the Director of Nursing for the Department for Public Health. So glad you could join us for today's Public Health Nursing ITV. Someone has their mic open. If you all could check your mics. You got it? Thank you. Today is April 24th, 2014. And our first presentation is going to be about hepatitis A. TJ Sugg, who's an epidemiologist within the Division of Epidemiology and Health Planning here at the department, is going to be providing our first presentation. This does meet the requirements for both the nursing CEs for 1.2 nursing CEs, and then I believe is it 1 hour for ERRT hours. So at this point, I'll turn it over to TJ, and so glad you all could join us today.
Thank you, Joy. Also, before I get started, I didn't think to tell Joy this ahead of time, but Andrea Flincham's presentation on HAIs, that will also be 1 hour of Epi Rapid Response Team continuing education. And I am working with Joy and Education and Workforce Development to archive these sessions, and we'll offer those at a later date too. So if you're not able to participate in the Public Health Nursing ITVs, you can access them at a later time. So we will try to get that done soon. So all those that we had last year and this year, you'll still have access to. So, all right. So we'll go ahead and get started with our presentation for today. The presentation that went out yesterday, I think, had the wrong title slide on it, so this is the correct one. I didn't think to change that before I sent it to Joy, so I apologize for that. And of course, I have the correct date on this one too. So I gave a presentation on the 1st of April, and I used the same template. I just used different slides, and I forgot to change the title slide, so I apologize for that, for the confusion. So, and I don't think your version has the objectives because I left those off too in that version. So to briefly go over those, what we're going to discuss today. We're going to discuss the biology and natural history of hepatitis A virus, or HAV, and that's how I'll refer to it from this point forward, HAV. Explain the signs and symptoms of HAV, discuss the epidemiology of HAV, describe the investigation of HAV cases, and discuss public health interventions for HAV. So to give a little bit of history of how these viruses were identified, before they were identified, before hepatitis A and B were identified in the 1960s and 70s, patients with viral hepatitis, they were classified based on epidemiologic studies as either having infectious hepatitis, which was transmitted from person to person by the fecal-oral route, or serum hepatitis, which of course was transmitted by transfusion of blood products. When diagnostic tests for HAV and HBV were developed, HAV was found to be the major cause of infectious hepatitis, of course, and HBV was found to be the major cause of serum hepatitis. And then later on, the hepatitis delta virus was discovered in 1977, and that is a defective virus that requires the presence of HBV in order to replicate. So in order for D to thrive, or hepatitis delta virus to thrive, it has to have has to be co-infected with B as well. So that was a breakthrough, but some patients with typical signs and symptoms of viral hepatitis, they didn't have the serologic markers of HAV, HBV, or HDV. So they were categorized based on epidemiologic characteristics as having either parenterally transmitted non-A, non-B hepatitis, or enterically transmitted non-A, non-B hepatitis. In the 1980s, 2 additional viruses were discovered, of course, which was hepatitis C and hepatitis E. And HCV was found to be the major cause of... Make sure your mics are closed, please, or muted. Thank you. And of course, hepatitis C was found to be the major cause of the parenterally transmitted non-A, non-B. And HEV is the major cause of enterically transmitted non-A, non-B hepatitis. However, so we've identified A, B, C, D, and E, but there's still a mystery that remains unsolved. There are still patients with typical signs and symptoms of acute viral hepatitis but they don't have the serologic markers for any of the A, B, C, D, E viral hepatitis viruses. So recently they have identified new viruses, but there's not really an assay to further characterize them at this time. So that remains to be determined, what those viral causes are. So a little bit of background information about the hepatitis A virus. It is a picornavirus. Its genetic material is RNA instead of DNA. And the RNA is about, or the virus is about 27 to 32 nanometers in diameter. It's very, very small. And it is spherical with an icosahedral symmetry, which an icosahedron is this picture there on the slide. And an icosahedron has 20 triangular faces, 30 edges, and 12 vertices. So, I don't know, yeah, so here you'll see the triangular faces, you'll see 20 of those, and it'll have 30 edges, which are these here, of course, the size of the triangle, and then it'll have 12 vertices, which are these points that come up here. And this is a protein capsid that encapsulates it and protects that RNA. So they are pretty stable. Humans are the only natural host. It is stable at low pHs, a pH for about 1 to 2 hours, or at a pH 1 for about 2 hours. It is inactivated by high temperatures greater than 185 degrees Fahrenheit. It's also inactivated by formalin, chlorine, and autoclaving, which of course the autoclaving has to take place for at least 30 minutes at a temperature of 250 degrees Fahrenheit or greater. Complete inactivation in food requires heating to over 185 degrees Fahrenheit for at least 1 minute. And HAV may survive days to weeks in shellfish, soil, water, or marine sediment. This is an electron micrograph of HAV, and I wish I could have found a picture of a cell in comparison to this, because you'll see that these viruses are much smaller than even a single cell, and you know how small those are. So. And a little bit more history about HAV. The identification, or HAV, has been around for centuries. Actually, Hippocrates described epidemic jaundice as early as 400 BC. And further outbreaks of jaundice occurred in 17th and 18th century in Europe, and these were associated primarily with conflicts, wars and things. The earliest recorded outbreak in the U.S. was in Norfolk, Virginia in 1812. And HIV was likely one of the causes of camp jaundice or field jaundice during war times, because there were large outbreaks of this camp jaundice. And it's hypothesized that HIV was the major cause of that. And in 1967, Dr. Saul Krugman differentiated infectious hepatitis from serum hepatitis, which is on that first slide that we talked about. And serologic tests were developed in the 1970s, and then vaccines were licensed in 1995 and 1996 for HIV. So the symptoms of acute hepatitis, some people, particularly young children, are asymptomatic. And the symptoms, if they are present, they are similar regardless of the cause, either if it's from hepatitis A, B, C, other viruses, or even toxin exposure. So, it's kind of difficult to differentiate based on the presentation, of course, because these are pretty common symptoms: fatigue, fever, nausea, vomiting, loss of appetite, abdominal pain, dark urine, jaundice, which is, of course, the yellowing of skin and the eyes, light or clay-colored stools, diarrhea, which is more common in children with hepatitis A. You really don't see a whole lot of diarrhea in adults, and some joint pain. These are just some pictures of jaundice. As you can see on the right, there is a difference, a noticeable difference between the skin tone of those two individuals. And then, of course, you can see in this picture here on the left, the scleral jaundice. And that's probably the best way to determine if a person is jaundiced or not, because you don't, sometimes you won't know what that patient's normal skin tone color is, and sometimes it's just difficult to determine based on their natural skin tone. In 1988, there was an outbreak of HIV in Shanghai, and it resulted in 8,647 hospitalized patients. And with that outbreak, they found that the symptoms and the clinical findings that they found most common among these patients were jaundice, weight loss, malaise, fever, nausea, vomiting, abdominal pain, and arthralgias. And of course, you can see a large portion of them had jaundice, weight loss, malaise, fever, nausea, and about a little less than half had vomiting. And then for the clinical findings, of course, there were 87% had hepatomegaly, and you would expect that with hepatitis A. There's an inflammation of the liver. It is going to enlarge. And then a small portion of them had splenomegaly, skin rashes. 2% had mild edema. 2% had petechia, which are small hemorrhages in capillaries. And then less than 1% had cardiac arrhythmias. The process for hepatitis A, of course, it enters into the mouth. It's fecal orally transmitted. That's the most common mode of transmission for HIV. It is an acid-resistant virus, so it will pass through the or the GI tract. There may be some replication that occurs in the GI tract, but mostly it will get transported to the liver, which is the major site of viral replication. Virus will be present in liver, bile, blood, and feces about 10 to 12 days after infection. And virus excretion may continue for up to 3 weeks after onset of symptoms. This is just a graph that represents the concentration of HIV in various body fluids. And as you can see, there's a great concentration in feces, followed by serum, saliva, and there's relatively no concentration of HIV in urine. But of course, serum is what we use clinically to diagnose for the most part. So the clinical features of HIV. The incubation period averages 28 to 30 days, but it can range anywhere from 15 to 50 days. As I've said before, the illness is not specific for hepatitis A, because they're pretty general symptoms. Hepatitis A virus is excreted in feces for 1 to 2 weeks before onset and for up to 3 weeks after onset. The likelihood of symptomatic illness and hospitalization is directly related to age. So children, they're generally asymptomatic, but as you get older, adults will become more symptomatic as their age increases. And of course, there's no chronic infection that occurs from HIV, but once a person has HIV, there are protective antibodies that protect them for the rest of their life. This is just a summary of all the events that take place during an HIV infection. As you can see, there's a lot that's going on when a person is infected. So we'll start over here and just kind of walk through all of these. Of course, once exposure occurs, it's going to be here at week 0. So they're going to be exposed. And a little bit later, you're going to get some viremia, which the virus is going to enter the bloodstream and it's going to circulate and it's going to go to the liver, where most of the viral replication occurs. And as you can see, you'll start to see a small increase here during the first 2 weeks in the ALT. Of course, those liver enzymes will start to increase. And then about week 1, you'll start to see HIV in stool. It will start being shed in stool. And also at week 1, you're going to start seeing an increase in the IgM levels, the antibodies that your body are producing against this. And of course, clinical illness will start around between week 2 and 3, and will last until about week 8 or so. As you can see, the ALT, or the IgM levels will increase gradually. And then about week 8 or 9, they'll start to, about week 7, they'll start to decrease a little more steeply than they were initially. And you'll see that they don't actually go all the way to 0. So you're going to have some levels of IgM, for several weeks or months after infection. But about week 2, between week 2 and 3, you'll start to see IgG levels increase. And so there's a point here where IgM levels and IgG levels will equal each other. And so it's kind of difficult to diagnose, if a person's in an acute phase, or has been recently infected if they're tested around this time frame here. And we'll talk a little bit more about the laboratory data in just a few minutes. So the serologic laboratory test for HIV. There are several different lab tests that you'll see. You'll get several different lab reports. And these can be a source of confusion depending on what kind of test the clinician ordered. So it's really important to pay attention to what is actually being reported on there. So For instance, there are viral hepatitis screening panels. There are two types. There's a hepatitis panel that's acute with a reflex to confirmation. So if it identifies the presence of something the first time, it will reflex to go back and to do a confirmation. And of course, with that one for IgM, the first test that they do for HAV is an IgM. Of course, they do a surface antigen, I think, for B with that one, and then just an antibody presence for C with this panel. But you'll get an IgM result if they do this particular one. Then if they do a general hepatitis panel, for that one, we'll only report out total HAV antibody. And that happened recently with a case. There was a panel that was done, but it was the total antibody for HAV that was reported. And I'll tell you a little bit about that later, that case. And then there's HAV antibody, IgM. Of course, that would help you identify an acute phase HAV. Then there's HAV total antibody, which is if the clinician sees the need to test or do some immunity screening before they administer a vaccine, they can do that test to see if they have something, if there is some type of immunity present. And of course, that's going to detect any IgM and IgG antibodies together. And then there's HAV antibody total with the reflex to IgM. So, of course, this will identify prior or acute infection with or immunization to HAV. So this is our surveillance case definition. It was revised in 2012, and it hasn't changed since then. So in order to confirm a case, the clinical description is an acute illness with a discrete onset of any sign or symptom consistent with viral hepatitis, such as fever, headache, malaise, anorexia, nausea, vomiting, diarrhea, and abdominal pain, and either jaundice or elevated serum alanine aminotransferase, ALT, or aspartate aminotransferase, AST levels. And then you also have to have an IgM antibody to hepatitis A virus that has to be positive. They have to be IgM positive for anti-HAV. And in order to confirm a case, you have to have a case that meets the clinical case definition and is lab confirmed, or a case that meets the clinical case definition and occurs in a person who has an epi-link with a person who has a laboratory confirmed Hep A, such as in a household contact or a sexual contact with an infected person. So as I said, the transmission occurs through the fecal-oral route. And of course, it can also occur through close personal contact, through household contact, sexual contact, or child daycare centers. It can occur in contaminated food or water, such as through infected food handlers, raw or undercooked mollusks, and contaminated produce such as strawberries and lettuce. And we've had some hepatitis A outbreaks associated with those in the past. There could also be blood exposure, but that's very rare. And of course, that occurs usually through injecting drug use and rarely by transfusion or clotting factor concentrates. This is a geographic distribution of HAV. As you can see here in North America and Australia, there's a low prevalence of HAV, and in Western Europe. But if you take a look at Latin and South America, Africa, Indonesia, they are higher and intermediate to high levels of HAV. So those are endemic areas where HAV is still pretty prevalent. This is the incidence of hepatitis A in the United States from 2000 to 2011, and as you can see, there's been a dramatic decrease, since 2000 in the incidence of hepatitis A cases in the U.S. I think there's like a 90% decrease since 2000, and of course, that's partly due to, mainly due to vaccine and public health interventions that we have now for hepatitis A. This is the incidence by age group, and as you can see, probably around 2004, all age groups got pretty similar in their incidence rates. But you can see that the 20 to 29 year age group has remained pretty high for several years, or is the highest one affected. And then the 0 to 9 year age group is, of course, the lowest. And this is just a breakdown by sex. As you can see, males have been more affected than females with hepatitis A. And of course, here in 2011, they're pretty close now with their incidence rates for Hep A. And this is by race, the incidence by race. And Asian Pacific Islanders, of course, tend to have the highest rates of HAV, and blacks and whites have the lowest here in the U.S. And with all of the data that they've collected, in 2011, we on that hepatitis A form, they ask information about risk factors and risk behaviors. And this is a summary of that data, those risk factors and behaviors. And as you can see, 13% had a risk identified, 46% there were no risk, or there was no risk identified, and then 41% of those cases they had data missing regarding the risk, the behaviors and exposures. And the behaviors and exposures that they asked for on the hepatitis A form is having traveled to an endemic area, having sexual or household contact with a confirmed hepatitis A case, being a child or an employee in a daycare center, or having had contact with such persons, being involved in a foodborne or waterborne outbreak, being a man who has sex with men, or an injection drug user. So here's a breakdown of that data for each of those risk exposures. As you can see, out of a total of, I can't remember, 1,398 cases, 27 reported contact with a household contact or had a close contact with an infected person. 13 were in child or daycare. 30 had contact with a daycare or child employee. 56 were due to a food or waterborne outbreak, and then 15 had other contact with the hepatitis A patient. As you can see, there's a lot of missing data in there, so it's really important that we try to collect that. I know a lot of times it's difficult to collect that information with those patients, but it's really hard to draw any kind of conclusions from this information, except for we have a lot of missing data. And for risk behaviors, of course, international travel, with 49 reported there, 15 reported injection drug use, and 2 reported that they were men who had sex with men. So investigating a case. The investigation of anytime that you get a report of hepatitis A, we ask that you make an effort to well, it needs to be a priority until you confirm whether it is a true case or not. Because of the incubation period, and in order to do effective post-exposure prophylaxis, we need to identify these cases early, because if you do post-exposure prophylaxis, more than 2 weeks after they're exposed, it's not going to be as effective in preventing infection or illness. So of course, it's an urgent public health matter. We want you to confirm the diagnosis in the index case. And of course, if you have any questions, feel free to call us up here. Sandy Kelly is now the consultant for hepatitis A, but if she's not available, I'm happy to help you with that, or Dr. Brawley, or any one of us up here. So if there's ever any doubt, give us a call and we're happy to help you. Of course, as I said, there's a limited timeline to provide post-exposure prophylaxis. The secondary attack rates can occur in households. It is kind of high. It's 15 to 30%. So it's really important that we do effective PEP as soon as possible. And then, of course, after you identify that case, we need to maintain surveillance for 50 days after the last exposure, just to make sure that no one else develops signs or symptoms. And of course, the best infection control is hand washing and contact precautions for those individuals. So for post-exposure prophylaxis, people who are exposed to HAV who don't have a history of hepatitis A vaccination, you can give them a single dose of single antigen HAV vaccine or immune globulin as soon as possible. And of course, these are listed in the 2006 ACIP recommendations for Hep A vaccine or pre and post-exposure prophylaxis. Healthy persons aged 12 through 40 years, they can get a single antigen HAV vaccine at the age-appropriate dose, and that's recommended over IG. Children younger than 12 months, give them IG. They can't take the vaccine yet. Adults over 40 years of age, it's preferable to give them IG, but use a single antigen Hep A vaccine if IG is unavailable. Immunocompromised persons or persons with chronic liver disease or persons for whom the vaccine is contraindicated, give them IG. And persons given IG for whom vaccine is also recommended, they can be given a dose of vaccine simultaneously with IG. We had an outbreak when I was a regional epi in Lexington, Fayette County, back in 2005, 2006. We had a hepatitis A outbreak in a school, and so we had to do these mass vaccination clinics, and so we administered IG and Hep A vaccine to a lot of these school-aged children. And then, of course, people who are given the vaccine, they should they should complete the series. So it's important to follow up with them. If you do have some kind of mass post-exposure prophylaxis, such as those clinics in a school or a daycare center or something like that, it's important to follow up with those individuals and make sure that they get their second vaccine. And we did that, and it was very labor intensive, and to track all those individuals and make sure that they did follow up. So if you have HAV in a food handler, of course, we recommend that you do environmental inspection of the establishment. For environmental cleaning, you can use a 5.25 to 6.15% chlorine bleach solution for surfaces. And I know in that handout that you all have, it says a 1 to 10. That's okay, but you don't have to go that concentrated. I think that's a 10% solution. So you can use a 5.25 to 6.15, and that will be effective as well. 10% might be a little difficult on the hands. So you can go as low as a 5.25 and it would still be effective. For post-exposure prophylaxis, you can either give the single antigen HAV vaccine or IG, and that should be given to other food handlers in the same establishment. And of course, high risk of HIV exposure to patrons. There is a high risk of exposure of HIV to patrons if the food handler had diarrhea, if the food handler had deficiencies in personal hygiene, if the food handler prepared foods that were not heated, and if the food handler directly handled cooked foods. So as I've said earlier, any response with the vaccine or to IG, that has to be completed within 2 weeks of the last exposure for it to be effective. And of course, maintain surveillance for 50 days after last exposure. For childcare, PEP is indicated for all previously unvaccinated adult staff and attendees when one or more cases of Hep A are recognized in children or adult staff, 2 or more households of attendees have cases, and you only need to treat the contacts of index case in centers that have no children in diapers. And for an outbreak, we consider that 3 or more families have hepatitis A. Treat members of the household with attendees in diapers. All right, now let's talk about the different ways that we can do prophylaxis. We have IG and we have the vaccines. So for HAV prophylaxis with IG, IG of course stands for immune globulin, and what that is, it's a sterile preparation of concentrated antibodies that's made from pooled human plasma. And they process that, and they test it to make sure it's safe and there are no infectious diseases in there that could be transmitted to other people. But it is used for it is concentrated antibodies from pooled human plasma, and they get this from people who go to the plasma centers and donate and things. So IG it provides protection against HIV through passive transfer of antibodies, of course. And these HIV concentrations, they differ, or anti-HIV concentrations differ among the IG lots, and slightly lower concentrations have been observed over the preceding 30 years, probably because that the prevalence of HIV infection is decreasing among plasma donors. But there's been no clinical or epi evidence that there's any kind of decreased protection from those. So for pre-exposure prophylaxis with IG, use 1 dose of 0.02 mils per kilogram given IM, and that will confer protection for about or a little less than 3 months. And then a dose of 0.06 milliliters per kilogram confers protection for about 3 to 5 months. And then for post-exposure prophylaxis, when administered within 2 weeks after exposure, 1 dose of 0.02 milliliters per kilogram is about 80 to 90% effective in preventing HIV infection. And of course, the point we keep driving home is that the efficacy is the greatest when IG is administered early in the incubation period. And when it is administered later in the incubation period, it may not prevent infection or illness, but it will attenuate the clinical expression of it. So, they may exhibit, milder symptoms. So this is the schedule, the immunization, or the doses and the schedule that you would use for IG. This is out of the ACIP, the 2006 ACIP recommendations. And I sent that to you, or I think Joy sent that to you as one of the attachments in there. And I'll talk a little bit about that in just a few minutes. So these are the recommended doses and for pre-exposure and post-exposure. And then for the vaccines, there are two kinds of vaccine. There's single antigen vaccines and combination vaccines. The single antigen vaccines, of course, only have HAV in them, and they are inactivated whole virus vaccines. There are two types that have been licensed and are on the market, Havrix and Vacta. Havrix is a GlaxoSmithKline product, and Vacta is a Merck product. Then, of course, there's the combination vaccine that includes HAV and HBV, and the one that is licensed now for use is Twinrix, and that's a GlaxoSmithKline product. Single antigen vaccines have been highly effective. For adults, over 95% have been seropositive after one dose, and 100% have been seropositive after 2 doses. And in children over 12 months of age and adolescents, over 97% were seropositive after 1 dose, and 100% were seropositive after 2 doses. And this is the schedule for single antigen vaccines. As you can see, for Vacta, for 12 months to 18 years, this schedule is given at 0, and then 6 to 18 months afterward. And then for over 19, of course, you can see the dosage here, and the schedule is the same, 0, and then 6 to 18 months after that. And then for Havrix, for 12 months to 18 years, it's given the same way, 0, and then anywhere from 6 to 12 months. And then over 19 years of age, this is the dose here, and number of doses, of course, would be 2, and then the schedule is given at month 0, and then any time between 6 and 12 months after that. And for combination vaccines, of course, that's Twinrix, and that's a combination of inactivated HAV and hepatitis B surface antigen in that vaccine. And it's licensed for people 18 years of age and older. It was licensed by FDA in 2001 for a 3-dose schedule, and in 2007, FDA approved a 4-dose accelerated dosing schedule. This one is indicated for people at risk for both HIV and hepatitis B viruses, and this one should not be used for post-exposure prophylaxis for acute HIV infection. So if you're doing post-exposure prophylaxis, use IG and the single antigen vaccines. And this is the schedule for the combination vaccine. Of course, this is recommended only for people over 18 years of age, and the schedule is given at 0, 1, and 6. And so for, the recommendations for routine pre-exposure. For children, all children should receive Hep A vaccine at age 1 year, and the vaccination should be integrated into the routine childhood vaccination schedule. In children who are not vaccinated by 2 years of age, they can get vaccinated at subsequent visits. And of course, international travelers, it is recommended that they get routine pre-exposure or pre-exposure prophylaxis. So of course, susceptible persons traveling to or working in high or intermediate risk countries, they should receive pre-exposure prophylaxis. Give a single antigen HAV vaccine or IG before departure. Single antigen HAV vaccine at the age-appropriate dose is preferred over IG, of course, because IG, the immunity will wane over time, whereas the vaccine will confer, a longer immunity. Healthy persons aged 40 and younger, they can get a dose of single antigen HAV vaccine given at any time before departure. It should be effective. For older adults, immunocompromised persons, and persons with chronic liver or other chronic medical conditions planning to depart to an at-risk area in less than 2 weeks, give the first dose of single antigen HAV and give IG at the same time at a separate site. Okay. And for international travelers who refuse the vaccine, give them a single dose of IG if they're going to be there for up to 3 months. But if their travel is expected to be longer than 2 months, give them 0.06, the higher dose of IG, and that will have to be repeated if they're going to be there for longer than 5 months. So, educate them if they're not going to be back to see if they can get that second dose of IG if they're going to be there beyond 5 months. And then, of course, completion of the HAV vaccine series is necessary for long-term protection. For occupational groups, healthcare workers are not routinely recommended to get the HAV vaccine. Childcare centers are not routinely recommended. Sewer workers or plumbers aren't recommended, but food handlers may be considered based on local circumstances. And then for persistence of antibody, of course, as I said, these have been shown to be pretty effective or highly effective. Persistence of antibodies, so far, they've been able to see at least 5 to 8 years among adults and children. No cases in vaccinated children or no cases of HIV have occurred in children that have been vaccinated. Mathematical models for antibody decline, they suggest that there is a protective antibody levels that will be persistent for at least 20 years. And of course, other mechanisms such as cellular memory, they may contribute to the efficacy of this vaccination as well. Pre-vaccination testing, there are circumstances in which that would be beneficial. Of course, you have to weigh the cost versus the benefit in that testing. Of course, considering the cost of the vaccine, which would be cheaper for the individual. Of course, consider the cost of the serologic testing. Prevalence of HIV infection, and the impact on the compliance with vaccination. And of course, this would be likely cost effective for individuals who were born in areas where of high rates of HIV infection, because they may have been exposed or ill previously, and so they may have immunity. Older U.S. born adults or older adolescents and young adults in certain groups, such as Native Americans, Alaska Natives, Hispanics, and IDUs. Post-exposure or post-vaccination testing is not recommended for single antigen HIV vaccines. There's been a high response rate among vaccinees, and there's really not a commercially available assay that's sensitive enough to detect the protective levels of vaccine-induced antibody. So I put this in here just to show you how effective these vaccines have been in the United States. So as you can see here, starting in 1966, we had increases and decreases in the incidence of hepatitis A cases. Here in, I think it was 1996, the vaccine was licensed for children who lived in high-risk areas. There were certain cities in the United States that were seeing these incredibly high rates of hepatitis A infections, and the vaccine was licensed for those children. And then later on, in 1999, the vaccine was approved for use in 11 high-risk states. We had 11 states in the U.S. that had incredibly high rates of HIV infection, and in 1999, that ACIP recommended use for those 11 states. And then in 2006, the vaccine, of course, became part of the immunization schedule. And as you can see, we've had this steady decline in cases. And as I said earlier in that other slide, since 2000, the incidence of hepatitis A cases has dropped 90%. So, here are some references, and of course, a lot of the material that came from this presentation were found by going to these links. So if you click on this link here, and I don't think you all have that, but I think Joy sent them to you as attachments, so you have PDFs of them. This is just a website. This is hepatitis A information for health professionals. They have a lot of information about surveillance and statistics, which is where I got those slides for hepatitis A. So you can find a lot of information here. And then for healthcare providers, there's overview and statistics. What is hepatitis A? And then there are links to other resources here too. This. And if you click this link here, it will take you to a bunch of resources, and one of them is the ABCs of hepatitis fact sheet, which is you should have received as an attachment. If you take a look at that, it's a really nice summary of hepatitis A, hepatitis B, and hepatitis C. And it starts with statistics, routes of transmission, who are at risk, and it goes on down the serologic test for infection and things. So this is a really good resource to have, just as a quick reference. Back here, and of course you'll see a link here to the Pink Book. I know that's a great resource that we use here, and so this is the section on hepatitis A in the Pink Book, and so you'll see a lot of good information and statistics here, and management and investigation of Hep A. And let's see the other link. I'll pull up the PDF. Just pull up the web page. You all received the PDF version of this, but this is the recommendations of the Advisory Committee on Immunization Practices. These were, I think, released in 2006 for the prevention of Hep A through immunization. And this is a really good article. It starts about, gives some basic information about hepatitis A, goes into the epidemiology of it, and then it talks specifically about IG and hepatitis A vaccines and the recommendations. And those tables that I had in the presentation actually came from this article. And I'm sorry if it's making you drunk, me going down that fast. But you can see the tables here too for the dosages and the schedule and things for administration of those. So. And one thing I do want to remind everyone of, whenever you're completing, whenever you're investigating a hepatitis A case, and it does meet case definition, I just want to cancel. And it does meet case definition, and you're completing the form. There is a CDC form for hepatitis A that we would like for you to complete. It doesn't go into the food exposures, which is important because it is a fecal-oral route of transmission, and it can occur through contaminated food. So we've had discussions here, and we revised the enteric disease investigation form to make it a foodborne, waterborne illness investigation form, and we included hepatitis A on that. But after several discussions and things, we decided to take that off of that form. So we may create a separate form because there's just a lot of confusion with doing the Hep A form plus doing that enteric form too. So we may blend the hepatitis A form from CDC with a food history, so we can at least get that information. So so we may decide to do that. That's something that we're discussing, and so that may be coming later on this year. But that's one of the things that are lacking whenever we're trying to investigate hepatitis A cases is a food history. And those always kind of come up, especially if there's a food handler involved or something like that. So, so just stay tuned for that. But I do want to say that it is important to try to get those risk behaviors and the risk factors to collect that information. And the lab reports, if you have, like I said, if you have any questions about the interpretation of the labs, you have to have an IgM result in order to confirm it. So if it's total antibody, the person may have been vaccinated before. So that could be something too. If you don't have information about if they had jaundice or not, check their vaccination history. And if you get a total antibody and you don't have any, and it's not possible to do an IgM on that specimen or get the patient back in to have them tested, check to see if they have an immunization history. A lot of the adolescents, and we had a case recently where there was an adolescent who presented with symptoms of acute hepatitis, and They did a panel. It was just a general panel, and it was not the one that reflexed confirmation. And it was just a total antibody that was reported. And the nurse who reported it, said it was IgM positive. But then once the health department actually got it, it was a total antibody. And we didn't have any more lab data from the individuals. I think they just had some slightly elevated liver enzymes, but really nothing that would make us think, yeah, this is definitely a Hep A case. So since it was a total antibody, we really couldn't go on that. So we did some further investigation, looked up, or the regional epidemiologist contacted their provider and their family provider, because they had went to an urgent treatment center, I think, to get that test done. Went back to their provider, and they did have an immunization history. It was an adolescent who received 2 vaccines. So, of course, they're going to have a positive total antibody because they did get vaccinated. So, anyway, those are just some considerations. So, I'll open it now for any questions.
TJ, this is Teresa Casey from Bear River District Health Department.
Yes.
On the clinical case definition, you guys have put just elevated ALT and AST. What levels do you want it to be up to start really considering HAV?
According to the case definition, CDC said just any elevated, because I think before it had to be over 100. But then they revised it in 2012 and just said elevated. So anything above normal. So, it's difficult to do, and we'll just have to take those on a case-by-case basis. But you should, if there are elevated, I don't want to say don't do it if there's only 1 or 2 points higher than what it should be, but because it's difficult for the individual to do that. So we have to look at the overall presentation of it and see what other lab tests are available at the time. So. There's really not a cutoff for that. It just said elevated, and that's what the case definition said. So we'll have to look at each individual case to determine whether it would meet that or not. So sorry, I can't say specifically. Well, if it's 5 or more, or 5 or less over, you don't have to do that. But we just can't do that. So. Any other questions?
I have a question.
Go ahead.
How are the ERT attendance verification forms and that process going? Is that helpful to the field for the regional FBs?
Yeah, so I don't know if you all heard Joy's question. She asked about the ERT continuing education forms and how that's going. The feedback, for the most part, the feedback that I've received from the regional epidemiologists, they like the forms. It's an easy way for them to track the ERT continuing education hours. So yes, go ahead and submit those. And as we said early, this session that I just did on Hep A, that's 1 hour, and then the one that Andrea is getting ready to do is an hour too. So you'll need to submit 2 forms, one for each presentation, so we can track that. Okay.
And I did, for the field, I did receive a request to begin including the regional FBs on the email distribution list.
Yes.
So I'm gonna work with you, TJ, make sure that list is, you maintain it, I'm assuming.
Yeah.
Right?
Yeah.
Okay. So that's current, and so if there's any names that need to be added or taken
I'll do
off,
that before
you'll
yeah.
do that.
Yeah.
I was gonna let you own that.
Yeah.
And then I'll just go in and add that.
The listserv to it.
Yeah, that listserv. Okay, and I hope that works for everybody. I'll just add them to the other folks that I
Okay.
email.
All right. Sounds good.
Okay.
Yeah, that's great.
Okay.
Any other questions?
TJ,
Yes.
this is Paula from Estill County. I might have a silly question, but if hepatitis A is highly transmittable through fecal matter, why would not sewer workers and plumbers be at a high risk?
That seems to come up every time there's like a flood and you have a lot of people out there. I don't know. There really hasn't been any data to show that is transmitted a great deal here in the United States, through that manner.
Probably because it's not endemic.
Yeah, it's not endemic now
So they don't
in
have as
Africa
much
and in South America, probably so. We just have a low prevalence of it here in the United States. In areas, such as Africa, South America, yeah, they probably would be recommended to get vaccinated there. But no, there's not really been any documented, large cases of a number of cases of the exposure or those workers being exposed through their work. So.
Is there a question?
My question was about efficacy. It says your mathematical models of antibody decline suggest predictive antibodies persist for at least 20 years.
Yeah.
Now, is that data only because we really don't have data past 20 years?
Yeah.
Okay.
Yeah.
All right.
And so Joanne asked a question about the slide that talks about efficacy and the 20 years. As of now, most vaccines, their protection wanes over time. And so, since this is relatively new, we don't have a lot of the historical data to say exactly how protective these will be in the future. So
Well, I guess the reasoning was you have a lot of young adults that are going into missionary work that were vaccinated back in 1996. You're looking at 2016 coming up. Do we
Right.
make recommendation for them to be revaccinated before they do any international travel?
That's a good question. I don't know. I don't know if there's any data that would support that at this time. I would say not until there are other recommendations and they get more data about the long-lasting effects or the long-lasting of the vaccine. So.
Fair enough.
All right. Great. Well, now I'm going to turn it over to, I guess Joy is going to introduce her.
Certainly.
Thanks, TJ. Yet another excellent presentation.
My
Appreciate
pleasure.
you. Appreciate you. All your expertise. Next, it's my pleasure to introduce Andrea Flincham. Andrea has her BSN, her MPH, and she is a certified infection control nurse. And today she's going to speak to us about healthcare-associated infections. She is the program coordinator for the HAI program here at the Department for Public Health. So she brings with her as well, she's our subject matter expert, and she has a lot of information about how HAI works and partners with local health departments. And so we appreciate Andrea being here with us today. Your presentation's all ready to go, so thank you again so much for being here.
Good morning. Can everybody hear me, see me?
Your camera's right here.
Oh, hello.
There you go.
Had to find it. Well, I'm sorry, I'm a little disheveled. They told me TJ was running ahead, so I ran up here and didn't even get to put my lips on. So I don't usually present without my lips, but you all will just have to bear with me. Hope everybody's doing well, and you can hear me okay?
Yes.
Okay. I'm going to talk to you about healthcare-associated infections today, a matter that is near and dear to my heart, as probably a lot of you all have experienced issues where things have happened in healthcare, untoward events, whether it's infections, medication errors, anything like that. These are preventable events, and so we have a whole program here that is dedicated to trying to reduce and eliminate these never events. Let me hit the right button here, sorry. Okay, we have some objectives here in front of you, and hopefully we'll hit all these. So let's get started. So think back, for those of you that have been in healthcare and have been nurses for a long time. I won't say old nurses, but seasoned, well-seasoned nurses. You remember the terminology nosocomial? And this is sort of the evolution of HAIs. Everybody remember nosocomial? That was what we learned in nursing school, and that's what we taught. That's what we called those infections that happened in the hospital. And it's kind of interesting to me, when you hear that word, you know what it means, but it doesn't really, it's not like a finger point. You know, it doesn't really, healthcare workers know what it means, but the general public and your patients and so forth don't really understand that term. so it didn't really make us look very bad, and we could say nosocomial and move on. And I think that's part of our problem. That's what we did. But then we evolved to hospital-acquired infections, and that was the terminology that was vogue for a long time. Now today, which I think is the most correct, we talk about healthcare-associated infections. And that's really important for public health to understand because they can happen anywhere. HAIs, healthcare-associated infections, are infections that patients get, or residents, as in long-term care, while they're receiving treatment for other medical and surgical conditions. So, for example, you go to the hospital, or you go to an outpatient surgical center, or you go to an outpatient dialysis center. You might go somewhere for physical therapy, and you pick up an organism or an infection that you didn't come there for, you didn't sign up for, but that's what you leave with. And as I said before, these are considered preventable and sometimes referred to as never events. And I think when that information became public to the federal government that these were considered preventable and referred to as never events, that's really when they sat up and took notice and started to dedicate resources, mostly financial resources, towards helping work on this problem across the country. The evidence has been there. We know what to do. Some of it is actually pretty simple, like hand hygiene. But, you know, getting people to actually do that is a bigger problem. So as I said, HAIs occur in all kinds of settings. And what's really interesting about healthcare today, as you know, it's complicated and a little convoluted because you have people moving all over the place. You have home care, you have hospitals, the acute care facilities, outpatient centers, and then long-term care. And it's been amazing to me when I've been investigating events that have been reported to us, just tracking one patient, the movement that patient does in one community between multiple hospitals and multiple long-term care facilities. I don't understand that. I don't know why it happens, but it happens everywhere. And in our state, we have people coming across the lines, across the state lines in, people going from our state out, and then going from county to county to receive their medical care. And really, right in the middle should be public health, because we are the people that are situated in the middle that can connect all the dots. So HAIs, I'm going to give you some statistics. These are the most recent that I can find, and it's a little bit, I think, a little bit scary still. 1 in 25 patients hospital patients on any given day will have at least one HAI. 1 in 25. In 2011, there were 722,000 HAIs in acute care hospitals. And approximately 75,000 hospital patients with HAIs died during their hospitalization. Now, a couple of years ago, the statistic that we shared was about 99,000 patients died in hospitals from HAIs. So we have made a little bit of progress, but if you or your family member is one of that 75,000, it's not fast enough, is it? And I think this is really interesting, too, because more than half occurred outside of the ICU. And in the beginning of all of this, when a lot of attention was paid to HAIs in the beginning, a lot of it was concentrated on the intensive care units because they're probably the highest risk area for medical care anywhere. You know, those are where our sickest patients are, and they have more tubes, more lines, are on immunosuppressive drugs, and so forth. So the fact that more than half of them occurred outside of the ICU really, I think, drives home the point that there's a lot of care going on in other places that is as risky to our citizens as being in an ICU in a hospital. The other thing that I will say about this data is that when you see that a lot of it is hospital-based, it's because we still don't have a ton of data on these other facilities, other kinds of healthcare facilities like long-term care and so forth. We're just really in the last couple of years beginning to do some big work in long-term care in outpatient dialysis centers, particularly those two, because it is a high risk, and those patients move back and forth a lot. Long-term care residents oftentimes go to dialysis at an outpatient center 3 times a week. They may have an event while they're sitting in the chair and they end up in the hospital. When they're better, they go back to the long-term care and back to their 3-day-a-week routine, and it's just happens over and over and over. So the data is coming very slowly in other facilities. So looking at the kind of infections we're talking about, in 2011, you can see on this table there, it has listed your major sites of infection like pneumonia, GI illness, and so forth, and the estimated number. I think that's really interesting. And the gastrointestinal illness, you all can attest to that because you report those norovirus and GI outbreaks all the time. And then to look at, we talked about the human cost and those numbers, but it's always good, I think, to talk about dollars. In a lot of settings, the dollars are going to be the first thing people talk about. I really like to do it the other way because for us as nurses, the dollar is really the last thing we consider. It's more the impact on human life. But you can see that these can be very expensive. Estimates now, and this is a little bit dated, this data, but just the first line, that our healthcare costs in this country are up to about 33 billion excess dollars spent on HAIs. I think we can think of a lot better ways to spend this money. So, as I said before, HAIs do occur in the outpatient settings. We just don't really know a whole lot about that burden, but I will tell you what we do know. We know that ambulatory care is defined as care where patients do not remain overnight. So they can be hospital-based or non-hospital-based outpatient clinics. And here's a list of some of the areas where people do receive health care outside of a hospital setting. And there's been a huge shift. We all know that people are not in the hospital as long as they used to be or as often. 3/4 of all surgeries happen in ambulatory surgery centers. And if you've been a nurse for very long, that's kind of scary when you think about it. But it happens. I've had outpatient surgery, had surgery, and then went home, and it worked okay. My husband had it, and when I brought him home, I was a little nervous. I was an ICU nurse, and I was a little bit nervous about bringing this person home who didn't know his name 30 minutes before because of sedation and was just taken off the ventilator, and they're saying, take him home. I don't know what it's like for the general public, but that's the way it is now. And there are some more statistics here about dialysis and about outpatient chemotherapy, and those numbers are growing all the time. The issue with these outpatient areas are infection prevention and control. You know, in a hospital setting and in long-term care, infection prevention and control is mandated. It's mandated in hospitals by the Joint Commission. That's part of their part of the structure that has to be in place. You're supposed to have a robust program. And in long-term care, for the CMS validation, which is the equivalent to Joint Commission, those are who license the long-term care, they also have to have a infection prevention and control program. But it's really becoming more and more apparent that in a lot of these outpatient settings, there is nobody on site that does infection control on a daily basis. So that means they're not watching for hand hygiene. And that's really important, to monitor hand hygiene. Certainly, we all, at times, get busy and forget to wash our hands going in and out of a room seeing a patient. Once in a while that happens. But then, you know, if it's a habit, that's a whole different ball of wax. So somebody needs to be monitoring that. And with, for example, dialysis, you have patients who are immunocompromised, and that someone, a healthcare worker, is accessing an internal line, whether it's fistula or what kind of a device they have for their hemodialysis. And so it's important that there are certain procedures and protocols that are followed so that this is done aseptically. Here are some examples of, and if you were to Google this, you could find pages of examples of just horrendous practice in HAIs that have gone on around the country. I mean, we remember it hasn't been too long ago about the multi-state fungal bacteria outbreak, where people were receiving injections from multiple injections from single-dose vials. We had an Oklahoma dentist who, because of his lack of sterilization with his instruments, ended up spreading hepatitis throughout his population, and you can see the numbers. I mean, it's horrendous. Pain clinics, I don't know why it's common practice, but it is. I guess it's money-saving to reuse syringes, and that is astonishing to me that greater than 2,000 people had to be notified because they reused syringes. So this is an issue, and it's a problem. But as you can see, you know, necessity is the mother of invention. So for how many years did we watch Wile E. Coyote try to catch the Roadrunner, when really all he had to do was get Sonic the Hedgehog and it was taken care of? And this would be me with chopsticks. I would have to use chopsticks to hold my fork because I can't eat with chopsticks. So there is always light at the end of the tunnel. And as I alluded to earlier, finally I was working in infection control in a large academic medical center, and we knew what the problems were. We recognized it. We were sort of isolated in our world of hospitals and referral centers. And it was like, does the rest of the world not realize what's going on here, that this is a problem? And then, voila, the light went off. And Dr. Frieden from the CDC has decided that this is a winnable battle and has set that as a priority. And so it's been good since then. This is one of his big priorities, and this has been a few years ago. So the next few slides are just resources for you. So I'm sure you all visit the CDC website often. But you can, here are some pages that I think are really good. There is actually HAI pages. This SHEA, the Society for Healthcare Epidemiology of America, has some great guidelines. And we got the Healthy People 2020. We have the Joint Commission. If you're involved in hospitals at all, we've got pages on specific organisms like Clostridium difficile, our friend, C. diff. There's a page on MRSA. There's pages on other organisms like ESBLs, if you haven't been familiar with those and it comes up, or Acinetobacter, God forbid you have to deal with that, or CRE, some of those other organisms. Just to review, we do have outbreak reporting of HAIs in Kentucky, and it's the KAR 902 KR 2:020. I don't know if that's how you say it right. But anyway, you all are very well versed and aware of this regulation. And the thing that I'm pulling out of this to share with you today is that anytime a healthcare facility, doesn't have to be a hospital, any healthcare facility sees an unusual pattern of events, then they need to report that to public health. And we are actually doing a really good job. In the last 2.5 years, and I haven't been here much longer, that's about as long as I've been here, but in that time, the amount of reporting has skyrocketed, and the request for us, the HAI team, to come and help with outbreak investigation in healthcare facilities is actually surpassed what we can do. And so we're kind of juggling that, but we are working to help bolster the regional EPIs with their knowledge in HAIs, and certainly at the local health department level, we hope to be pushing out a lot of education over the next year or so to you as well, so that should a healthcare facility, whether it's long-term care, hospital, whomever, call you with questions about these sort of things, you could at least get started. But if nothing else, if someone calls you and they have issues like that, please pick up the phone and call us or send us an email. So let's talk briefly about some common HAI organisms. Clostridium difficile currently is the most prevalent organism that we're seeing in healthcare. And if you don't know what Clostridium difficile or C. diff is, it is a spore-forming organism that causes diarrhea. And it's normally found in the human colon, has been cultured in large numbers of newborns, and then as time goes on, it's less and less prevalent in the gut. But it works at a balance in the gut, just like everything does in our body, and it's okay to be there normally as long as it's not causing illness. And what happens when folks get too many antibiotics and it kills the normal flora in the gut, then the C. diff takes over. And it can take a healthy colon all the way down to a pseudomembranous colitis, which usually ends up with megacolon, sepsis, and death. So you can see in the first picture what a healthy colon looks like on an endoscope, and then what a pseudomembranous colitis looks like, which is usually a fatal disease. Modes of transmission, as I said, antibiotic exposure is inappropriate use, especially, and of antibiotics is one way that it can be acquired. The other is transmission through, and I hate to say these two words in the same sentence, the fecal-oral route. I mean, they really don't belong together, do they? But it happens, and I have to tell you all a story. Before I left the hospital, I got a call from our employee, one of the employee health nurses, and she said, I just saw a nurse and a nursing assistant from one of the floors in the hospital, and they tell me that they have it's humorous, I'm telling you, they have acquired C. diff on the job, and they want to know if they can get workers' comp. So, I mean, I actually laughed. I had to put the phone down and laugh, because how did they get that? Think about it. Fecal-oral route. That means somebody wasn't washing their hands, and what was going into their mouth? Why you would ever admit that in public at your job, I do not know. Obviously, there was an opportunity here for some education. But, and I feel bad for them, because C. diff is a horrible illness, and nobody wants to have that. It's really pretty easy to avoid. If the environment is contaminated, you wash your hands. If you're dealing with patients that have C. diff, you wear the appropriate PPE and you wash your hands. So, let's see. Sorry, we'll skip that. Let's talk about the prevention measures. As I said, patients are placed, and this is in any healthcare setting, long-term care included, they're placed in contact precautions. So you're gowning and gloving to have any contact with that patient, resident, or in their environment while they are what we call active disease. So they're actually having active diarrhea. In some cases, people choose to wear masks and goggles to keep, if you have somebody that's having copious amounts of liquid stool that you have to deal with, you can have splashes in the face, so that is a good thing to do. Because it is a spore-forming bacillus, it's really hard to kill, and so what you have to know is you got to wash with soap and water. Alcohol does not kill C. diff, and the environment has to be clean with 10% bleach. That's for disinfection. And that's really hard in some settings, particularly what we run into in long-term care, because in a lot of long-term care facilities, you have grandma in there who took her cherry chest of drawers, most treasured possession piece of furniture, with her. I've been in a lot of long-term care facilities, and you've got quilts and crocheted items and all kinds of stuff everywhere, and then you have a resident that has picked up C. diff. And how do you disinfect with 10% bleach with those kinds of items? That's a hard thing to deal with. But you may get calls, and I think it happens in the local health departments that folks will have C. diff in a facility and want to know what to do. If you ever need any help with that, please do not hesitate to give us a call. So let's talk for just a minute about MDROs, which are multi-drug resistant organisms. A multi-drug resistant organism is a bacteria that is resistant to most classes of antibiotics. And it's really a result of overuse of antibiotics. If you think back a few years ago, and my children are late 20s, early 30s, when somebody had an earache, you went to the pediatrician and they prescribed 10 days of amoxicillin. And if there was still fluid behind the ear in 10 days, they would give you 7 to 10 days of Bactrim. And then if there was still fluid behind the ears, they would give you another 8 to 10 day course of a bigger antibiotic. I mean, and this was the practice for years. So that's a lot of antibiotics, when probably what they needed was a decongestant to get that fluid to drain. But this is how we have used antibiotics in our country, and so the organisms, this is like survival mode, and they are very well suited for survival. And they do. So the drugs are becoming less and less effective. And I will tell you that, and I have a slide, never mind, I don't want to give that away. So this is just a little picture of what has happened. If you look at the top, you see all these antibiotics, and it's on a timeline starting at 1930 and going up to 2005. So you can look across there and pick out an antibiotic, like vancomycin came into play at about 1956. Then if you look on the bottom side of this table, when was resistance to this antibiotic observed? Well, actually, vancomycin has been effective probably longer than most. It was about 1987. So that's what, 30, 31 years that vancomycin was actually effective. Look right under that at methicillin. 1960, it worked till about 1961. And that's pretty much how it's gone. And so that doesn't mean that it was completely rendered ineffective, but that's when the first resistance was observed in laboratory specimens. So that's a real problem, because if somebody has an infection that is resistant to all antibiotics, what does that mean for them? It most likely is not going to be a very good outcome. If you have a pneumonia and it is resistant to all antibiotics, you know, that potentially is a fatal condition. And how does this occur? Well, we have non-resistant bacteria, and they multiply and multiply and multiply, and then somebody decides they're going to look different and they mutate, and then these mutations multiply, and those mutations are, as I said, a mode of survival. They do this in the presence of antibiotics, and pretty soon, you have all these mutated bacteria that do thrive and are very proliferate. So then this is just another rendering of how antibiotics, how its mechanisms of antibiotic resistance. And so there's lots of different ways it can happen. It's not just one set pattern. It's pretty complex. I'm not a microbiologist, but I can look at this and tell you that if there is a bacteria that has been able to mutate and is completely resistant, so all of these modes are in place, that's a pretty smart little bug. MRSA, let's talk about this for a minute. Methicillin staph-resistant aureus, Staphylococcus aureus. Penicillin discovered in 1928. It was not widely used till the 40s, but by the 50s, Staph aureus became resistant to penicillin. That didn't take long. Methicillin, we talked about this a second ago, was introduced in the market in 59, and by 61 we had resistance developing again. So that really just goes to show how determined this Staph aureus is to survive in the presence of antibiotics. And by the 70s we were seeing outbreaks of MRSA in hospitals across Europe and the US. This tells you a little bit about the bug. It's a gram-positive organism, and it can cause lots of different things: food poisoning, toxic shock, skin abscesses, bacteremias, osteomyelitis, endocarditis, scalded skin syndrome, and pneumonia. And this is from 2007, and I think these numbers are probably changing a little bit, that a good deal of them were healthcare associated and small were community associated. For you guys in the health departments, you're probably seeing a lot of community onset skin abscesses would be my guess. But invasive infections, though, there's a lot that are seen outside of the hospital. So this is, I'm sure you all have seen these before. It's pretty gruesome. Most of the time when you see something like that, that's going to require incision, drainage, and possibly even IV antibiotics. So somebody might be spending, a few nights in the hospital with that. MRSA 300. For those of you in the south part of the state, you all have dealt with this before. We had an outbreak or a small cluster of necrotizing pneumonia that was caused by, some of them we were identified as MRSA 300, which is a very, very virulent strain, but it was secondary to influenza. And so these folks had not gotten flu shots, had gotten the flu, and then subsequently, because this is a very common organism in the community, gotten this necrotizing pneumonia. So some emerging HAIs, most of those are gram-negative organisms. Those are the ones that are harder to treat and wreak more havoc on the human body. There's really nothing in the pipeline right now new for gram-negative organisms, and it takes a long time to develop new drugs in this country. We have multi-drug resistant Acinetobacter baumannii. That one is especially hardy. It lives in the environment as long as 30 days. It can be in sand, it can be in dirt, it can be on your tabletops. It doesn't really care where it is, but it will live, and it can mutate very, very quickly. So this is a horrible organism to get into a healthcare facility and try to get it out. CRE is carbapenem-resistant Enterobacteriaceae, and that's another emerging pathogen. We've done a few sessions on CRE. If that's something you hear about, we see it a little bit in long-term care and a little bit in hospitals. Some of you all have processed reports and helped us investigate events of CRE. Prevention. Antimicrobial stewardship is huge, and that's really limiting the inappropriate use of antibiotics. We have to improve hand hygiene among healthcare workers and the public. That's huge. And there are a lot of evidence-based practices that are scientifically studied, researched, that work. And they actually are shown to reduce HAIs by 70%. You remember that number in the beginning. We had gone from 99,000 deaths a year to 75,000. So something is working. But I don't think that was 70%, but it's going in the right direction. And then identifying outbreaks as soon as possible to limit further spread. So let me tell you just a little bit about antimicrobial stewardship. This is a startling number to me. And I knew we were in a bad state of affairs, but I didn't know how bad until the CDC called me one day and they said, so are you going to start working on this problem? Kentucky has the second largest use of, or prescriptions filled in outpatient settings of antibiotics in the nation. Second largest use. We are neck and neck with West Virginia. So, some numbers say we're first, some say they're first. We'll just take second on this one. But that's 1,205 per 1,000 persons in our state. That is our rate of antibiotic usage. And so what is that doing to us? Well, it increases C. diff. It increases multi-drug resistance. And then the thing that is really scary about this is that when people do get infections, it makes these drugs useless. And so it increases mortality and morbidity by over and utilizing antibiotics and inappropriately. I mean, how many people have felt bad, gone and got an antibiotic, you feel better, especially sinusitis. This seems to be a big one, or upper respiratory infections. You feel better, and you forget to finish the med. So what have you done? You've really given that organism, that bacteria, a roadmap, because you gave them just enough to kind of knock them back a little bit, but then you didn't continue. I don't mean you personally, but you didn't continue, and so now they've figured it out. How do we become resistant? Because they've opened the door and they've given us the information. So how do we stop this? These are some strategies that are used around the country. It is really attacking two areas, providers and then patients in the public. I don't know which one is the hardest. So providers really need to understand what is appropriate and not appropriate prescribing. The CDC has a Get Smart, Know When Antibiotics Work campaign for the outpatient setting. They have a website, and I think it's on another slide. It's phenomenal, the materials that they have. So, but they really need to try to educate folks on when you need antibiotics and when you don't. Because your child has green snot does not necessarily mean that they need an antibiotic. Maybe they need some fluid. Maybe they need a decongestant, something along those. Maybe they need a Kleenex. You know, it's not. That doesn't mean they absolutely need an antibiotic. But as a parent, when you take a child to the doctor, you think they're sick, you want something to do for them. And so some places are making out prescription pads that have alternative treatment options. So when that parent leaves, they have something in their hand that is giving them some advice and strategies to get their kid well. I mean, that's really what we always want when we take our child to the doctor, right? The other option is to consider delayed prescriptions. And there are a lot of physicians that are doing this now, and this is actually very effective in some settings. And I've had a doctor do this to me. Well, I think you have a virus. I think you're going to be fine. If you're not, here is a prescription. If you're not better in 5 days, then fill it. I didn't fill it. I was fine. I mean, the doctor was right. It was viral, and it did run its course. So patients and parents and the public, how do we educate them on not expecting an antibiotic every time they go to the doctor? That'll be a huge educational push for Kentucky if we're going to get out of this second status. I mean, that's terrible. And then we need to teach people that viruses do not need antibiotics. So here is the Get Smart, Know When Antibiotic Works website. Go to that. It has teaching materials for providers, and it also has teaching materials that you can share with your patients, put out in the waiting rooms and things like that in your clinic areas. So this is the HAI program, and when I typed this up, I looked at that and I thought, man, it looks like I got a lot of people. I really don't. I will tell you, Dr. Sands, the third name down, is part-time. Dr. Gronwald, my CFO, is part-time. My student research assistant is part-time, and Dr. Brawley is, of course, the medical director who hangs out in our area and oversees everything. But here is our contact information, and if there's anything we can do for you or anything that you need, please don't hesitate to call. And if there's any questions, we got plenty of time for questions. That was so good you don't have any? Or is everybody asleep?
Let me ask this. When TG did his presentation on HAV, he mentioned that the environmental cleaning can be reduced, the mixture of bleach can be reduced to 5.25 to 6.25. Do you think that's something that would help with the quilts and the bedding in the long-term care facilities? I mean, is it the same for
No, to my knowledge, it still has to be 10% bleach for Clostridium difficile. And, I think the only thing that's going to help in that setting, and we have counseled facilities, you need to figure out why you have C. diff and get that stopped. And if you can't get a handle on that, then you're going to have to
Hey, Frankfurt, you're sending out a black screen. Sorry to interrupt, but you're sending out a black screen.
Okay, how's
There
that?
you go. Thank you.
You would have to discourage people from bringing that kind of stuff in. And if I were an administrator in a long-term care and you wanted to bring your furniture from home, beautiful wood furniture, I'd make you sign something and say, look, if we get, C. diff in here, this has to be cleaned with 10% bleach. Do you really want to do that? And if so, you need to sign. That doesn't stop anybody from getting upset or lawsuit or whatever, but, we need to educate folks on the front side in those settings.
So are you going to do a mass media campaign directed toward providers that prescribe antibiotics?
Well, I'm in the process of writing our grant,
Okay.
and talk about it. Is anybody good at writing grants? I'd buy you lunch, dinner, breakfast. You can stay at my house until we get this done. One of the projects that we can potentially write to, and we've been highly encouraged to do this, is work on antibiotic usage in the outpatient setting. And so they have a lot of strategies, and I think that we will get a little bit of money from this. What I'd like to have, if my dream came true, would be a certified health educator who can work with not only the public message, but providers. And we need to, what is suggested now is we need to go back to medical schools and start giving that information more. Dr. Gronwald was in Hazard at the first of the week and gave a lecture to some residents who work at Eastern Kentucky Veterans Center, residents as in physician residents. And he was talking about antimicrobial stewardship. And he said that some of them looked a little blank. And so he said, so you all have had this in med school, right? So and there is a huge push with the CDC. They recognize that that has to be part of the curriculum in medical school to learn how to prescribe antibiotics appropriately. And there are some strategies in the hospital that can be used. Oftentimes you have a patient in the hospital, even in a nursing home, that spikes a fever, has signs and symptoms of an infection. They don't know what it is. They don't know what the organism is that's causing it, but they want to start treating right away. And that's okay. So what they usually do is throw big gun antibiotics at this and obtain cultures. So once that culture information comes back from the laboratory, then you have to sort of de-escalate and tailor those prescriptions based on those results. Sometimes that happens. In a lot of places that happens, but sometimes it doesn't. So we're still throwing big guns at something that really only needs a little gun. That's a huge, huge strategy. And then the other thing is putting in hard stops in these electronic medical records so that if a physician gets on and orders a big antibiotic, then they're going to get a message that comes back and they're going to have to justify why they want to use that particular antibiotic, because some are have been finger pointed more for developing resistance than others. So if you can stop them from prescribing those unless they absolutely need it, but you've got to have an electronic health record first, and then you've got to have IT support to build in those kind of stops. And then the other piece of that is to have a robust enough pharmacy program that can counsel them on what needs to be done. So, in the bigger academic medical centers, UK, U of L, places like that, that is in place. But, when you get into smaller facilities, that's a way down the road. But we really need to work on, so if anybody wants to sign up to be a Say No to Antibiotics cheerleader in your community, I would love to have you. I think one way to reach the public will be through focus groups. We'll be looking to pilot this somewhere. Could be in your neighborhood. And then try to take the program statewide to educate the providers and the public? That's a great question. So get your pom-poms out and be ready. Say no to antibiotics. We'll do commercials, I don't know. Yes, ma'am.
Is this a particular issue, the overprescribing of antibiotics in a certain region, or is it across the board, or a certain facility type?
Well, it's in facility types, it's outpatient prescribing. There isn't, we don't have a lot of data in Kentucky. What I have is, I think it's 2010 was the last that I was able to obtain, and it's how many prescriptions are filled in a particular county. I don't know where that prescription was written. We only have one county where there were no prescriptions filled, and that was Robertson County, the smallest county in the state. What, there's 2 people there, I think. I don't know. I'm teasing. I'm so teasing. I think there's 4. But I can tell, I mean, I know what county has, it's all ranked, so I know who had the least and who had the most. But from the literature that we get from the CDC, it looks like pediatric offices are probably the highest offenders. And you can understand why. When a parent has a sick child, you know, Katie barred the door because they want something to fix that child. And I was one of those parents. So I certainly understand what that's about. And sometimes, you know, it's just easier to say, here. I don't know that a lot do that. I do know in long-term care, we do hear a lot from them that families are so pushy about, and maybe that's the wrong word, but that they want, you know, now daddy's confused tonight. You know that's how he gets when he gets a urinary tract infection, so call the doctor and get an antibiotic. And many times they cave. And they call the doctor and they say, well, you know, the daughter's saying daddy's confused and he's always like that when he gets an infection. And so they send a prescription for an antibiotic. Happens all the time. So there's education that needs to happen on both sides of the fence. Anybody else have questions? Those are great questions. Thank you. Anybody else? Are you stretching or raising your hand? I think she's stretching.
I think she's stretching and looking real. Any other questions for Andrea?
All
Thank
right.
you so much,
You're
Andrea.
welcome. Thank you for having
Busy
me.
schedule, Mr. Grant,
Yes.
and so,
Wish me luck.
yeah, absolutely. Learned a lot about antibiotics and being a cheerleader.
Yes.
We're not right.
Just say no.
That's right. Thank you again.
You're welcome.
Next, Brooke, if you'll come on up. Next, we're going to have Brooke Skelly, who is a Department for Public Health Fellow with the CDC, and she also is located and works within the Division of Epidemiology and Health Planning. And Brooke has been working on a great project, which she's going to share and present to us today. It's entitled Health Risks and Resources Across Kentucky. So thank you, Brooke, for being here with us today. Let's see here if I can get your presentation up here for you. There you go. What about that? Having too much trouble? And your camera's right there in the corner, okay?
There are so many cameras. Where do you look? All right. Good morning. I'm excited to be sharing this with you guys today. I hope that some of the work that we've done, preparedness focused, but will be relevant to public health nurses across the state. Okay, there you go. Thanks. So I'm going to start by providing an overview of functional access needs and introduce the health risks and resources across Kentucky tools and discuss kind of the purpose for developing those tools and then show you how you might use them. Before we get started, I want to give some background and some terminology so that we're all on the same page. The term functional and access needs I can't see that far away. Refers to people who cannot comfortably or safely access and use standard resources offered in disaster preparedness, relief, and recovery. And FEMA has given 5 functional areas: communication, medical care, maintaining independence, supervision, and transportation. And so those are kind of the functional areas that members of the FAN populations may have additional needs related to these. For those of you who are familiar with preparedness, you may know that CDC has 15 FEP, Public Health Emergency Preparedness capabilities. And this slide, I just want to point out a couple of things. FEP capability 1 is community preparedness. And the capabilities have different functions and tasks and priorities. But what I just want to point out is that in this capability 1, we are tasked with determining the risks to the health of the jurisdiction and then needs to support mitigation of those risks. So that's kind of the background for where this all came from. This was done, the jurisdictional, functional, and access needs population risk assessment was done to fulfill FEP capability 1. And so we convened a work group and a preparedness staff and epidemiologists to prioritize and guide progress on this jurisdictional assessment. In order to conduct this jurisdictional assessment, we compiled data from a variety of sources and then use that data in tools that were developed to share that information. So the tools are called Health Risks and Resources Across Kentucky, and they include county-level indicators for FAN populations and location information of resources critical to public health planning and response. The overall goal is to help foster improved planning, response, and recovery efforts by providing information so that local health departments or local emergency planners can have a greater awareness of the resources and the risks in their particular communities. So as I said, I'm in the preparedness branch, and we certainly have our own set of goals, primarily to improve our planning efforts and response and recovery. Accomplishing this by presenting up-to-date county and regional information in centralized, accessible formats. We found that people may have information about their county population indicators, but it's not all in one easy place to get to, and we wanted to make that useful by putting it in one accessible format. Encouraging data-driven, community-focused planning and response efforts. That's another FEMA initiative, a whole community philosophy that you plan for who's in your community, that the whole community is incorporated into both the planning and the response and recovery stages. And then providing opportunities for local and regional collaboration, so allowing local health departments and partners to identify resources, resource gaps, and training needs pre-event and try to address some of those things. Our hope is that the information can be used for preparedness planning, but also for some other tasks. So strategic planning, assessing health vulnerabilities, conducting a community needs assessment, the accreditation process, which we have some health departments that have already completed, but some that are working on that, so hopefully that will be useful. Grant writing and collaboration with community partners. These are some examples that we kind of thought of and that other people suggested. So, if you find some great way to use the information, let us know, because we'd like to share that so that others can benefit too. All right. Now that we've developed the framework, I'm going to talk about the actual tools. There are tools in 2 locations. There are tools in WebEOC, which is the Emergency Operations Center for internal preparedness users. So I'm not sure if many of you have access to that. And then there's the resources on the public-facing website. And I'll get into each of these. So the population data that we collected roughly followed a CMEST definition for FAN. I mentioned at the beginning of the presentation. So these are age, communication, so looking at vision difficulty, hearing difficulty, non-English speaking, health and medical, looking at some prevalence of different chronic diseases, diabetes, looking at dialysis use or dialysis treatment, people who are dependent on dialysis treatment, supervision, especially long-term care, and then mental and cognitive impairment, and then some other determinants. We realize that this is not comprehensive, and if you're really doing community needs assessment, there's some more population-specific things that you might want to look at. What are your geographically or culturally isolated populations within your area? But in terms of being able to provide information on the whole state, these are some really great places to start. That capability also says to include resources that might support mitigation of the health risks, and so we chose to include location information for some resources that would be critical to public health preparedness and response. And so those were local health departments and health centers, county emergency management offices, hospitals, pharmacies, and you can see the others. The population information was collected from a variety of sources. Probably the most used sources were American Community Survey and the Behavioral Risk Factor Surveillance System. So, WebEOC, as I said, is our Emergency Operations Center online for preparedness, for public health preparedness, and that has the age, communication, health and medical, supervision, mental and cognitive impairment, and those other determinants on there. You can view the data by county by clicking on a county name, or you can view it by the area development district. For counties, it'll pull up a PDF that kind of gives a county snapshot, which is cool. And then the ESF8 resources map. So ESF8 is the Emergency Support Function 8, which is Public Health and Medical Services, and KDPH is the lead agency for that. And so these are resources that are related to the location related to public health and medical related resources. So there's a map here that you can put those locations up. What I really want to talk to you guys about today, though, is the map that you'll have access to, the Health Risks and Resources map. It's an online mapping tool, and you can create and customize maps to compare health information across Kentucky. And I'm going to show you how to do a couple of those things. First thing is pointing out we partnered with the Kentucky Safety and Prevention Alignment Network to post this widget, this mapping tool, on their website. And you'll see the link, safekentucky.org, and then you go to the Preparedness tab. You guys see my cursor? Yes, okay. The Preparedness tab is here. It has an introduction about public health preparedness, and then goes into how to use it, right? Probably also can't see this, but there's an instructions PDF that gives step-by-step instructions that will go over everything that I talked about today and more to help you with that, as well as contact information and sources. So if you have any questions, you certainly can contact me in the future or visit this website for additional instruction. On the map, you can find, visualize, and share data. And so you can find find locations in a couple of different ways. There's a search bar at the top. You can just type it in. Here I've typed in Frankfort. You can enter you can click on a county. So if I'm just looking at the state map, I can click on whichever area or city that I'm interested in. Or you can use the zoom to zoom in to a particular area of the state. And then visualizing. So you can customize the map by adding data layers to visualize the population data and sites to visualize the locations. So, and I'm going to show you how to do each of those, but I want to, before we get started, the end product. This is a map with locations and population layers. To add data layers, you go up to the section where it says Add Data Layer, and you just put your mouse over either the demographics or health and mobility headings, and you're able to select from the indicators that I showed you earlier. So here we have estimated percent of all people age 5 and older who were non-English speaking between 2007 and 2011. So you can see the map, and I'll show you how to customize it a little bit more. The legend that I've blocked by putting those headings, but the legend allows you to select options for how the data is displayed. So if there's some data that you can look at older information if you're interested in that. You can look at whether you're looking at count, percent, or percent change, and the range of the data values will indicate whether you're in a count or a percent as well. And then how it's shaded. You can shade county, city, state, and in some cases, I think the total population, you can do it down to the census tract. So you can customize the data by adding or taking away boundaries. You can toggle on and off county lines, state lines, freeways, and roads. Down at the bottom here where the check boxes are. Here, if you put the county lines on when you're looking at the whole state of Kentucky, it's very messy. You can't change the thickness of them, but if you were to zoom in on one region of the state, it does show a nice division of where things are. So here's an example. Here's vision difficulty. This is the estimated percent with a vision difficulty between 2008 and 2012. I've clicked on Bath County, and I see that 5.22% of that county meets the criteria, which is has difficulty seeing or reading even when using glasses. And if you want to know what the definition is, there's the person. You can click on details next to the data title. So now we're going to look at some sites. How do you put locations onto the map? Well, just under the Add Data layer, there's a heading for Add Sites. And this shows all of the different site types. Here, Kentucky local health departments and health centers are on the map, and they're kind of evenly spaced across the map, but that's where those are. This is the first map that has placed the local health departments and health centers on an actual map. So being able to have that is pretty cool. Info bubbles. So every time you click on something, a bubble with information is going to pop up, whether that's a location that just tells you this is Bath County, or whether it tells you the particular health statistic for that location. Here I've put all of the pharmacies on the map, and they're color-coded by type, which is pretty cool. I'll show you how to do that in just a second. But here's Lexington. This is actually the pharmacy that I use, Walgreens on Pink Pigeon Parkway. And every time I call they say, "Where's your pharmacy?" and I tell them, and it inevitably creates laughter. So anyway, so you can put on the site types, and then when I click on that Walgreens, it tells me what type it is. It tells me the location, what county, and the phone number. There are some, pretty much we have the address and phone number for all of the location types. There are some that have additional information, so if the health department has a website, you can also find that on there. On retail-based health clinics, there are some, also some websites. And so by clicking on that, you get the additional information. You can search within a particular site type. So once you've put the locations on there, so this is local health departments, you can just click that button next to search, and a search menu will pop up at the bottom. I started typing in Barron, and it gives me the option for Barron County Health Center or Barron River District Health Department. So it kind of does like, when you Google something, it autofills. And so then I can click on what I want. Here you can see in the info bubble, it has the website. I want to point out one more thing about location. you can put more than one location type at a time. If you do the whole state, it gets a little busy, but say if you wanted to see in McCracken County where the health department, the county emergency management office, and all of the pharmacies were, and you wanted to zoom in on your county, you could do that and produce a map with that information. You can also filter to get some additional details, which I did with the pharmacies. Here I've done it with the trauma centers. I put trauma centers on the map and then filtered so that the different levels are different colors. You do that by just next to the X to remove the location type, there's a double arrow, and it tells you which filters can be applied, if any. And then lastly, downloading and printing. This information, you can download each data set that you look at to a CSV just into Excel. If you want to download the count and the percent, put the count on, download, and then change it to percent and download. It doesn't give you everything all at once, but you are able to get both pieces of information. And then you can print. So by clicking the print button, you can save the picture as a JPEG and print that out, which is this orange button right here. Right here, this is another picture. This is estimated percent of adults with diagnosed diabetes, and then retail-based healthcare. So your little clinics in Kroger. So I think that's it. Does anyone have any questions about the adding any indicators to the map, or?
I have a question. This is really, really neat. Several questions. One, I think I heard you say you all put together data from 2008 to 2012, right? Because otherwise it's hard to get that county level data.
Right. So the data that's from American Community Survey is the 2008 to 2012 number.
Okay. So who will keep that updated? Who does that? That's one question. And then the other question is, what's the program behind this? I mean, you know, and then I had a third one, but gosh, I forgot what that is, so it'll come back to me in a minute.
Okay. This will be maintained in the preparedness branch by the person who does the functional and access need populations coordination. So I will leave, I'm a fellow, so I'll leave in July, and the person who's responsible for FAN will take that over, and it will be updated annually, probably around this time every year.
And then what's the software programming behind it?
So it's we use PolicyMap, which is a totally web-based GIS system, and you can go to their website, policymap.com/maps. In order to download county-level information, you have to be a subscriber, but with the widget, we can put on just the information that we want. Sarah, do you have anything to add about PolicyMap?
No, but with the subscription, we receive the ability to produce 3 widgets, and this is one widget. So this is what this is called, a widget. So, yeah, this way to display data. So with that, we are also, Brooke contributed data that we compiled, and then also some data were already available from PolicyMap, like the American, some of the data were already there. I think the diabetes and obesity data, am I correct? Already on PolicyMap.
I believe diabetes was.
And they had already put that out there. So we kind of combined forces with them. And then they were great to work with.
And the reason I'm asking is we've been looking for something like this with a couple of the other groups, with Trudell Panetti and things. Only it really had to do with what coalitions and groups are working on health communities projects and things like that. And so this is really, if you put the data in, you can pull that, I mean, you can make the bubbles, the info bubble,
Right.
Which would say this coalition is here, and this one's working on obesity here, and that's perfect, thank you. That's great, thank you.
Do local health departments all have access to PolicyMap?
At this time, no. It's
They don't have access to the website.
They have
Our
access-
basic website, PolicyMap.
.com/maps.
Yeah.
If you don't do the /maps, you'll be lost forever. So they would have access to look at, I mean, it's mostly an economic development and housing site, honestly. Health is kind of a new thing, and then we uploaded our own data.
More toward health.
And so they have, like, treasure troves of information.
I mean, the amount of information, and then, too, they also, with the subscription, you can download, they've got whole reports with demographics and information that are very helpful, I think.
For example, for preparedness purposes, I downloaded a home heating fuel type by county. So, how many people are using different types of
I need that for the Addison grants.
Yes.
Okay, well,
It's just
and if you're
not-
interested in any data that, even if you aren't able to download it, if you want to contact me and I can download that and send it to you.
Perfect.
Yeah, there's, yeah.
Yeah, I know.
Sorry, I have more questions. No, I mean, I will, but yeah, because there's a lot of information, I think that you'll be interested in chronic disease. And we think it's very easy to use. It's kind of point and click and you're out there. But this site that Brooke's talking about, you don't need a subscription. It's out there for the public, so.
Yes.
And she's giving you the link, so.
So if you wanted to use it for another purpose.
Oh, sure.
How would you build that, I guess? So like if we wanted to do it for our healthy communities and all those kinds of things, did you have to buy a whole nother subscription and all that? I mean, what would you have to
Or
do?
more widgets?
Yeah, I think you would probably have to, either try to add that or buy a subscription specific to your program.
And there are different levels depending on how many users you need and how many widgets if you want to buy them a la carte or whatever. So it's embedded on. Here's the. Well, my favorite thing about the website is, I love looking at maps, and so being able to customize the map so that I can see just part of the state, or I can put long-term care facilities with the population under age 5. I don't know why you wouldn't put that together, but if you did, you can without having to create 10 times, I guess about 150 separate maps. You can do that.
Excellent information. And have you opportunity to share, I'm assuming, with the preparedness coordinators?
Mm-hmm. I've shared with the regional preparedness coordinators, with the Functional Needs Collaborative.
Mm-hmm.
It was sent out on an email to public health preparedness coordinators at the local level and local health department directors.
Good, great. I also see, as we've been talking, I also see a very close link for community needs assessment.
Absolutely.
As it relates to health and coalitions, I can easily see the utilization.
Right, and what's so nice is that you can see the data on the map, you can download those maps, and you can also download the data directly. So those people who love, like epidemiologists and all those who love working with the data,
Right.
you've got it right there for you if you want to use the data in another way, if you want to even map it a different way. You've got the data there for you in Excel.
When we were looking at we had pretty loose guidance based on that capability. It was kind of like, hey, you just joined preparedness. Conduct a jurisdictional assessment. What does that mean? So I looked at some of the health departments in Kentucky, what they included in their public health accreditation information. And so the ones who had that, like Franklin County, I looked at that and really benefited from seeing what they had included. But also, if you haven't finished it yet, use this to get some information.
And I presented before the accreditation coordinator
Oh,
before,
did you?
and I know that they really need county level data.
Yes.
And I know that the county health departments, that's what they really need. So I think any ways that we can think about getting that
And
data.
good county level data.
Yes, good, yes, definitely.
Are there other questions for Brooke?
Well, thank you all so much. And again, if you have any other questions later, feel free to contact me or Sarah.
You did an excellent job. Thank you. Thank you, Brooke, for coming. Just want to put the camera on. Hey, Joelle. Thank you. Okay, we're running relatively ahead of schedule today, so that's a good thing. I know that most of you all have participated in KPHA. There were contract training session yesterday, so I know it's a busy time and a busy week for everybody. I have a few updates from the nursing office, and also Sandy Clark is going to come up. She's section supervisor in maternal and child health over the school health program. and the Well Child program, and she's going to give us an update on House Bill 98 as far as the delegation of insulin and injectables, and she's going to talk to us a little bit about where KBN is with the training and the regulation, writing the regulations and how that all relates to our scope of practice and getting those trainings out there. So she's going to be here in about quarter till. So in the meantime, I wanted to bring you all up to speed on a few activities from the nursing office. As a reminder, Nurses Week is May 6th through 12th, and this year's theme is Nurses Leading the Way. And I wanted to make sure for the nurse leaders in the local health departments and our NEC members and our Department for Public Health nurses on mark May 8th to do a Save the Day for May 8th. We'll have a face-to-face CE offering, which will be provided free of charge to public health nurse leaders. It's going to be here in Frankfurt in our conference suites. I can't remember if it's A and B or B and C, but I'll send that information out to you as it gets a little bit more closer to time. Carla Bowman is going to be our CE presenter. It will be a full day, approximately 8:45 to 9 o'clock. It's probably about 3 or 3:30. So my next project on my to-do list is to work with Vi Allen and get that CE registration information to Vi Allen and get the train registration built. So hopefully we'll get that out to everybody next week so you can go ahead and register. But I wanted to make sure that we did have that on your calendars. I've heard from several of the nurse leaders over the last few years that they really do miss having that opportunity to meet and catch up with their colleagues, their nurse leader colleagues, and talk about share good times and current times and new times. And so this will be an opportunity to network with your colleagues and plus get a great CE offering with Carla. And the nursing office will be providing a box lunch as well. So mark your calendars, and as I said, I'll be working on that train information with Vi Allen. Hopefully we'll get that out next week. May 8th. I think that's a Thursday, Joan. Sandy Clark has joined us. I'll go ahead and break. You've got perfect timing, as always, Sandy. I've got one bullet down. I've got a couple more to go, but I don't want to hold you up. Nope. Why don't you come on up? And I'd already told them that you were on your way. As I mentioned, Sandy Clark is going to provide us an update on where we are, where KBN is with the implementation of House Bill 98. So I'll turn it over to you, and thanks. I emailed Sandy this morning and said, can you come up and talk to the nurses, and she was so willing and to come on up, and I appreciate that for that last minute, accepting my last minute invitation. That's what happens when you include me on email. That's good information to share.
Thanks, Joy. I just want to briefly update you. As you all know or may not know, House Bill 98 passed this spring, and it is the House bill that allows for insulin delegation to unlicensed assisted personnel. KBN, I've been very involved working with them through this process, originally had made a proposal that they were going to change their regulation to allow nurses to delegate pins and pumps only. Well, at the last minute, they decided they weren't going to do this, so they pulled this amendment April the 15th, and instead what they're going to go back and do, the board has to vote on it in May, next month, at their board meeting, but what they're going to do now is they're going to go in and change their advisory opinion statement, number 15 and 30, and they're going to allow nurses to delegate injectable medications. So this, instead of going to the regulation, they thought this would be easier. Now, in the past, what they had been working on was they had developed a medication training for nurses to delegate, to use for delegation on pens and pumps. So they're going to have to go back and add the addition about insulin syringes and vials with this. So if it gets approved next month, they're going to have to update the training material. They hope to have this available by July 1st. But to reiterate, the bill actually does not take effect until July 15th, which is going to be a push for the nurses in school starting, because most of the time, as you know, if you're involved with school health services, school nurses usually start doing their trainings after July 1, so it's going to be a short time frame. They will be putting, my understanding, once they get their medication module completed, they're going to put it on their website. KDE, Department of Education, is going to also put a link on their health services webpage directly to the link of the KBN model once this is up and running. And then the Board of Nursing, Pam Hagan, who took Sharon Mercer's place as practice committee, is going to be presenting at the Kentucky School Nurse Association conference, summer conference. They're now having a summer conference. It's going to be 2 days, but it's not till July 28th and 29th. So Pam's going to be there, talk about all this change, and then they're going to actually go through the medication administration, answer a nurse's questions and that type of thing about the training manual. So it is going to be a short time frame for everyone. There's really, they've had their hands tied, so it's been a very difficult process to try and get this far. One of the things I want to point out, which has come up to somebody's arm, sorry if you heard that little noise here, somebody's armchair fell off. But no one was injured. But one of the other problems with the Department of Education, their legal system is looking at this. The House Bill 98 recommends, but doesn't make it mandatory, that you use ADA's training module. The problem with this is ADA's insulin delegation training module does not require competency. And if you look at KRS 156502, it states in there that when you delegate to an unlicensed person in a school setting, they have to possess sufficient training and skills and demonstrate competency. So their legal department's looking at this. So that's going, if this is going to be an issue if nurses use anything else, like for instance ADA, which doesn't require competency, which what KBN worked on, their module did have competency check-off list and return demonstration, that type of thing. So this is something that's still a little, we haven't got clarification on, but most of the nurses that I have spoken with anyway would prefer to use something from KBN since they oversee our licensure. So feel free, if you have any questions, email me here. I'll be glad to try and answer them, or give me a call. I will keep Joy and everyone updated as I find out and see if this gets passed by the Board of Nursing in May. But as right now, this is the plan.
Would it be okay, Sandy, if I forwarded your email, or could you forward the email that you sent to me yesterday? Could you send that out to the nurse leaders?
Sure, I'll be glad to do that, Joy. I can do that. I'll send that out.
That's all wrapped up in a nice email.
Okay.
And it basically says what you just shared with the group, and that way everybody, they
will have that. Okay.
Yeah, if they didn't have the opportunity to participate in the ITV today, that would be great information.
I'll be glad to do that.
Okay.
Does anybody have any questions for me before I run back downstairs? Okay, thank you. I appreciate it.
Yeah. Thanks, Sandy. Okay, next I wanted to update everyone about the Nurse Executive Committee meeting that was held on this Tuesday. The meeting was almost entirely dedicated to the review and discussion of proposed CCSG changes. Wanted to let you know, I'll briefly go over those, but I wanted to let you know that there's, in general, and Joanne, you're here in the room, you feel free to add to my comments if, or any of the other NEC members that were at the meeting on Tuesday. In general, the changes were mostly related to formatting, updating references, that type of thing. There were some clinical changes, but I'll go through those, and then we'll of course we'll be sending that information out. The goal is to send both the CCSG and the administrative reference out the first week in June, and so local health departments will have the opportunity to provide their training, their staff trainings, obtain their physicians' signatures on their protocols, and be able to be ready to implement those by July 1st. We will be including with both the AR and the CCSG a listing of changes both for both documents. So that is what you all have requested, what local departments have requested in the past, and I think that you all find that helpful in your training to know what those changes and revisions are. So certainly we'll continue to provide that information to you all. Family planning, just going down the list as an FYI, since we've got a few minutes, the only change that's going to be made at this time is to the updating the references for the citations for the material. As Emily has shared, Emily Atkins, who's the family planning director, has shared with you all in the past, we do feel like the new Title X guidelines, which they have been working on for at least 2 years, perhaps 3, we hope that those will be released in the very near future. In fact, we're participating as one of the 50 state grantees. We're participating in a webinar this afternoon at 2 to learn and discuss more about those new Title X guidelines. We hope and we anticipate that those guidelines, from what Emily's been told in the past, will be more broad in scope and will be more based on national standards of care for regardless of a provider type, whether it be in a health department setting or a private physician, so forth and so on. So as soon as we learn more about those Title X guidelines, we hope that we'll be able to have a time enough for in between the release of those and the implementation of the July 1st CCSG. So, but as we discussed in the meeting on Tuesday, Emily said that the Office of Population Affairs may give us 6 months to implement those. And so we certainly, we don't know what they look like. So what we want to do is have a good review of that information, determine what the impact will be, the clinical impact will be on local health departments and clinical services, and from if there's any administrative changes, do a great assessment of those, and then work on those protocols. So it's something that we don't want to rush, but then on the other hand, we want to go ahead and make sure that you all have that information as readily soon as possible. So more to come on the Title X guidelines. HIV, Greg Lee presented, and he's going to include and update the HIV chapter with the rapid test information. And so that was basically the fundamental change in his section. Immunizations, there were several protocols that have been changed, and so those have each been reviewed and revised, and there's been some formatting and wording changes on those. The Kentucky Women's Cancer Screening Program, they do have some additional guidance on MRIs and the BRCA 1 and 2 assessments, so that information will be included. Laboratory and lead, just going down my list, laboratory, Susan Lawson made some changes, just clarifying language, and laboratory, Linda Daly actually included just some changes that didn't make the transition from the PHPR to the CCSG, and she said that everyone should be familiar with those changes, but wanted to still include those in the list, so you all could make sure that everybody was aware of those revisions in your agency. Oral health, wanted to let you know that Dr. McKee, she and I work together with her counterparts here at VPH and her coalitions. She is going to be adding a public health dental hygienist section, not in the AR and not in the CCSG. It will be on the right-hand page of the local health department homepage screen. When you all when you access the CCSG, it'll have, on the right-hand side, it'll have the hyperlink for the AR and the hyperlink for the CCSG, and then it has the hyperlink for the WIC manual, and so now there will be a hyperlink for the public health dental hygienist. It'll have the clinical protocols as well as the administrative guidelines. And we talked through that, And since the CCSG is for nurses, and this is a different discipline and it's an optional service, we want it to be readily accessible and available, but we wanted to make sure it kind of had its own identity and home as well. So that's where that information will be. Julie Miracle came and spoke to the group about the perinatal Hep B information, and she has 5 pages of clinical information, clinical guidance, as well as case management information and optional forms. That information is going to be housed in the immunization chapter. She felt like that's where, and she's talked to several of the nurse leaders, and they felt like that was a good home, appropriate home for that information. So that's where that will be included. Trina Miller provided an update for the prenatal program. Her information was mostly updates, formatting, a clarification on, Joanne, was it diabetes? What was her, do you remember what her update was on? It's on the matrix, on the page 1 prenatal matrix. So, but it was a clarifying point on that. And then she updated some of her forms as well. The TB program, Emily Anderson and Maria Dalby, they have 3 changes to make, and it's to add additional guidance information in the TB chapter, as well as add several new optional forms that they have worked and developed in conjunction with their, they have a work group for the TB program, and so they've run those through their program, and they presented those mostly related to documentation and working up a case, a TB case. And there's also information that is included for video DOT. And so there's a procedure and a policy related to the video DOT. So that will, I know many of you all have discussed that opportunity, explored that opportunity, and so I wanted to let you all know, wanted to be able to support that initiative with the proper paperwork and documentation and policy guidance. So again, just to wrap that up, as far as the CCSG, our goal is to have everything in place out to you all the first week in June, along with the AR, and the AR committee is one of our sister, of course, books, and that committee has been working in tandem right along with us on the AR, so they will be providing their updates to you all as well. Let's see here. Any questions about the CCSG? Okay. And then I wanted to let you all know, wanted to bring your all's attention to the local health department driver's manual that local health departments receive. Both the directors and the nurse leaders were sent late Monday afternoon or evening from Dr. White. And this manual, it's a as we look towards the future and review and explore different opportunities for local health departments to provide new or different or expanded services in your community. This is just a user's guide to kind of stimulate your thinking and have conversations with your director and with your team within your agency. So we are currently right now, we have about 6 nurses in the Division of Women's Health, and myself and our division director, Rebel Baker. We're conducting phone calls, conference calls with local health departments to discuss different opportunities that you may have in your community, what you've done and what you're looking at, and what your future may hold and may look like. So many of you all may be participating in those calls with us either today or tomorrow or Monday. So I wanted just to bring your attention to this driver's manual. It's a living document in that as more information becomes available, as more local health departments share their best practices and their experiences with different models and different business practices. We'll try to include those and have this be a document that will serve as a resource and reference for you all. So I just wanted to mention that. And then lastly, I just wanted to share with you all that I will be out of the office May 12th through June 9th. And so before I leave, I will be sure to send to you all the coverage for both the Division of Women's Health and the nursing office. So wanted to be sure to bring that to your attention. So if you email me during that time, you'll receive an out-of-office call, or out-of-office message, not out-of-office call, out-of-office message. And so I just wanted to let you all know that. And I plan to be back in the office that week of June 9th. So are there any questions, comments, concerns that you all would like to share with me now, or anything that I can help you all with? Everybody's, yes, hi.
Anybody else have any trouble navigating the 340B recertification?
Oh, okay. Jones asked about the 340B navigation. And so are you talking about, there's two, now it's 340B navigation certifications. You're talking about family planning. And you know that the TB 340B navigation is getting ready to come up. So I do know that there has been some confusion, and of course the federal government would have to have both of them going on at the same time. But if you have any questions, please contact either Emily or Christy Royalty, and they'll be glad to help you and walk through that. Are you changing your authorizing official or something like that? No? Okay. Has everybody else, have you gotten out on your family planning 340B recertification website yet? Is anybody else having any concerns? And I'll certainly share those with Emily. Glenda, have you done that yet? Glenda Baston?
Not yet. There was some changes that, from last year I printed it off so I would know it was incorrectly, but they had some incorrect zip codes and addresses on it, so I've got to do a change of request form, so that's
that's kind of holding you back then. If you do have questions or concerns or problems with that recertification process, please contact Emily Atkins or Christy Royalty, and I know they'll be glad to help you. Okay.
This is Debbie at Harrison County, and I've had trouble also.
Oh, have you? What problem did you have, Debbie? And I'll tell Em about it.
Just trying to get signed on and using the password and the login.
Okay.
I've contacted them, and they had reset it. So I've got to retry again, so I'm not sure.
I got past that.
You got past that?
Navigate these dashboards.
Oh, okay. Okay. And it may be that we can help you, we can do that from our end.
On how to do it.
We might be able to do it from our end and walk you through it, Joan, okay? Okay. Debbie, do you want me to have Emily call you? Or you want to call Emily and see if she can help you?
I'll get back with her. I had signed on like 5 different times.
Okay.
And one day it makes you wait like 15 minutes, so.
I know it.
And then I ended up calling the 800 number or 888 number, and they were going to reset everything. So I'm going to try that again, and if I still have issues, I will call her back.
Okay.
I'll call Emily.
Yeah, okay, that'd be fine. Yeah, call Emily, she might be. All right, you're welcome, Debbie. All righty, well, it's noon. Thank you all very much.
I'm sorry, can I ask you one more question?
Absolutely, yes, ma'am.
Hi, this is Lisa from Northern Kentucky.
Hi, Lisa.
We got an email from Greg Lee yesterday about the oral HIV training. It's going to be May 8th.
Yes.
Is that part of the Nurses Day?
No. Okay. And we learned that on Tuesday. I apologize. Is that going to, for that conflict, is that going to be at your all's region, or is that statewide?
He said it's in Frankfurt, but he didn't give a time. But I guess if you choose not to go to that one, you can work to have something locally, I guess.
Yeah. And Joanne's shaking her head. Yes, Thanks for reminding me, Joanne. That is what he shared with us at the NEC meeting on Tuesday. I
Okay.
apologize for that.
That's okay, I just wanted to, I wasn't sure if it was part of the same meeting.
Yeah, it's
Okay,
different.
thanks.
Uh-huh.
All right.
What other questions do you all have? Anything else? All right. Thanks, everyone, for all that you do for public health every day. Have a great rest of the week, and we'll talk to you soon. Take care. Bye-bye.